Oh, we are at 11:59, and as usual, we are going to go ahead and get things started. First and foremost, to everyone, thank you so much for joining us for this Crisis Jam for today. Today is a special edition, and I am honored to be your host for today. I'm Dr. Brian Sims. I'm the Senior Medical Advisor with the National Association of State Mental Health Program Directors, otherwise known as NASHPD. And it is my honor to host today's session. That is a special session, and it's going to be focusing on innovations in crisis care. There are a lot of things that are going on in the world, and we are going to try our best to address some of the issues, but we just wanted to open the doors to welcome everyone to the session and look forward to a wonderfully positive session today. If you'll go to the next slide, please. And as has been mentioned, and you see each week, here is the map showing the participation of the states and the national organizations. It is of note that the numbers continue to grow. We are talking about roughly 40 to 50 that have been added to the newsletter email list, which is really indicating that this is moving in a wonderful direction. You also want to acknowledge the fact that this is not just about domestic. We're also looking at a number of our international welcome participants coming out of Australia and Canada and the Netherlands and as well Great Britain. So we are looking at the world as opening the doors to this wonderful participation, and we welcome you into this session. Next slide. This is something that's going to be new, and we're adding this in as kind of a measurement piece. What they did was they took a look at who were the top jammers, and that's defined as who were the most active participants in the 988 crisis community. And after looking at those who have attended the most frequent, it was a close race. But as you can see from the pictures, there are a number of folks. But the number one person, the top of the list, is a person that we'll be speaking a little bit earlier, and that's Dr. Richard McKeon. So congrats to Dr. McKeon. And I've been told that all those who are pictured here will receive t-shirts. And since my picture's there, I will happily wear my t-shirt. But on top of that, we also would like to do shout outs to those that are in the kind of grayish blue where your pictures are not there. If you would be so kind to send us a picture, we'll be updating this each week, and you'll be able to hopefully see your picture. For those who already have their pictures, I've been told that if you don't particularly care for that picture, you're welcome to send us another picture and we'll upload that as well. Next slide, please. Now, in this particular section, this is our talk.crisisnow.com page, and it gives you all the information. And what's particularly interesting in here is that you'll be able to go both backwards and forward. And you've heard this many times before. You can click on particular links. You can take a look at some of the materials that were in the past, but you can also look ahead to see what is coming up both today, and you can sign up for weekly reminders or newsletters. So it's really helpful to have that information available to us. In that, you'll also see features and some of the videos that we've done in the past, and you can go backwards and check on things and get some ideas from it and even give us some forwarding ideas as to what you think should be included going forward. And next slide, please. Now, as the latest crisis news, and as many of you have already should be aware of, I'm sure, we've had significant events happen within the past 24 hours. We're going to speak to that in just a little bit. But this particular page we want to open up as our latest crisis news, dated out of mid portion of this month. That is really talking about something that we're seeing embracing across the 988 set to become a national crisis hotline in some of the states. It's moving in wonderful directions. I believe this is featuring Seattle, but we're looking at the fact that we are moving progressively more. If you look at the timeline, we have so very little time left. We're already exiting May and going into June, literally. So we'll be seeing that time of implementation, and it is a good measure to be looking at. Next slide, please. Now, on this particular slide, what I wanted to do was call on to speak on the Together for Mental Health, just to give us a little bit more information.
Hey,
Uh,
Brian, this is Shannon
yeah.
Scully from NAMI.
Okay.
Um, I'll jump in here really quick. We just wanted to make sure that everyone on this call was aware that NAMICon, our NAMI's annual convention, is coming up June 14th and 14th through the 16th. It's going to be a virtual event, so you do not have to travel and you can attend as much or as little as you want. There's going to be some great content, a lot of different tracks focused on youth and young adult issues, research, but most notable for this crowd is we are going to have an entire track on crisis response. Lots of great content coming from our partners at RI International. Also on June 16th, we will be having a day of visibility around 988. We'll make sure we get more of that information out to this crowd for ways that you can try to lift up the implementation and coming of 988 to your crowd. Additionally, on Wednesday, June 15th, we are going to be having a fireside chat between the Assistant Secretary for Samhsa, Dr. Delphin Rittman, and our CEO, Dan Gillison. It happens right after this call on Wednesday, so we'll make sure that we get that link out to everyone so you can just hop right on over. You do not need to register for NAMICon to attend that. We're making sure that's open to the public. Additionally, anyone on this call who has a large youth and young adult network, I also want to make sure that you know, anyone who registers as a youth or young adult, the conference for you is going to be free. We really want to make sure we're getting this content out to young folks and make sure that they're really connecting into our network. So I'll pass it back to you, over to you, Brian. The link on the slide, I believe my colleague Stephanie put the link to register and learn more about the conference, but we're super excited, great content, so check it out.
Well, thank you, because I was going to mention about the chat box, but if you look in the chat box, you will see the linkage for it. And thank you so much, Shannon, for that info. So let's go to the next slide, please. And the quote that we have for today actually comes from Scott Anthony at the Harvard Business Review. Many see innovations as sexy and mysterious, but innovation is a discipline to be mastered and managed. It is hard work. Getting good at it requires significant practice. So just briefly to just acknowledge the fact that this whole theme, the special edition, is going to be focusing on innovations. And it's an understanding of the obvious, and that is we are an innovative society, but it does indeed require us to work at it. And that we're good at doing it, we just need to work more. Next slide, please. And we are now ready for our featured presentation for this morning. And we are delighted to have Dr. Tom Insel with us, who's the author of Healing Our Path from Mental Illness to Mental Health. He's a former director of NIMH and NIH and DHHS, as well as an adjunct professor at Stanford University School of Medicine and the Department of Psychiatry and Behavioral Science. So Dr. Insel, I pass the floor to you, sir.
Oh, thank you, Dr. Sims. It's a pleasure to be here. I've been at many of the JAM sessions over the last, oh gosh, a year or so. If I can, just riffing off your last slide, Brian, about innovation as a discipline, it's an opportunity to be disruptive, and I want to disrupt today a little bit because I think we just need to call out the moment we're in. This event from yesterday has got to be on everybody's minds, especially anybody who has kids and grandkids. It's a horrific moment. And unfortunately, it's not an exceptional moment. We've just had way too much of this. I think we're all going to process it in our own ways. I keep thinking about a moment 15 years ago after the Virginia Tech shooting. I was the director of NIMH at the time, and President Bush asked me and Charlie Curry, who was the head of Samhsa and head of the CDC at the time, and then the Secretary of HHS, who was Mike Levitt from Utah, to to take a look at this issue of school shootings and to try to get some insights. And he gave us Air Force 2 to fly around the country. And within about 6-8 days, we went to, I think, 10 different states and met with governors and heads of universities and heads of law enforcement. And we came up with what I think was a really important report in 2007, right? To sort of make sure that this would never happen again. And it is happening again and again and again. It's more frequent than ever. We have had a doubling of active shooter events in the last 2 years. We have more firearms than we have people in this country at this point, 400 million. And of course, these automatic rifles or automatic, semi-automatic guns are selling at 2 or 3 times the rate of hunting instruments. So we're in a crazy, crazy place. And I've gone from being sad to enraged to sad to frustrated. And I guess I just feel like we just have to take a moment and say, how do we disrupt? How do we make sure that we don't continue on this path of self-destruction? Because that is absolutely what it is for our young people. I mean, we're in a country in which, 1.4 million people have been killed in gun violence since 1970. That's more than in all the wars that this country has ever fought. And that's over 50 years, and it's gotten worse every year. I saw a statistic this morning that there are more toddlers killed in this country than police every year through gun violence. I mean, there's just got to be some way that we begin to address this. And I wanted to call this out because there's, and maybe we can get this in the chat. There is I think a really effective and important piece that I hope everybody reads. It's in the New York Times this morning. Unfortunately, it's had to be reprinted multiple times. It's from Nick Kristof, and I can put it in if nobody else has. But the point that Nick is making is that, as Margie says, this is a public health issue, and we have to now take it on as a public health issue. That means that we all have a role. Thanks. I see Karen just put it in the chat. And what Nick is arguing, and what I argue in my book, which is right behind me on the shelf, called Healing, is that we have done this for other problems. And when we began to address automobile violence, automobile mortality as a health issue, we were able to reduce automobile fatalities by a remarkable rate. I think it was 70 to 80%. I go through that story in the book. We just haven't yet had the focus on this in the same way. We get it politicized, we get tribal about it. We have failed to really deal with it in the way we need to. So I just had to take this moment to say something about this. I think we all have got to take out a moment and ask, what are we going to do here? And I must say that we're part of the group that has got a stake in this as people who care about mental health crisis. That's a piece of this. And if we can do a better job, I think we can have a bigger impact. So it's a really important topic for us to put into the jam. It's, I think, an important topic to focus not only on the grief and the rage, but also on the solutions, and to say, what are we going to do? So going back to this idea of being disruptive, I promised David and promised Brian that I would go through the slides, and I will do that, because I do think we need to talk about innovation. And maybe this is part of what one of the solutions is for us, is whether we can do a better job in that part of the task that's on our plates to try to really make a difference. So with that, let's go back to the slides, and Rin, I'll just kind of run through these quickly. I want to talk about this from the standpoint, these are really slides I put together last week before I was thinking about what we were going to deal with this morning. But in thinking about behavioral health crisis, what struck me was that we've had so much innovation in the mental health space in the last 2 years, but broadly in the last decade. but maybe not so much in this space. And so I'm really bringing this to you with help that you'll help me and help all of us think about how to do this better. Next slide. When I left government I actually joined Google, what was this now, 6-7 years ago, it was to try to think about how can we innovate for mental health. And I came across a quote from Brian Chesky, who's the co-founder of Airbnb, in which he said, if you really want to understand how to innovate, Brian had been at Rhode Island School of Design. He said, just go for wherever the duct tape is. Look for areas that just aren't functioning in the way they should, where things have just been jerry-rigged or people are trying to get stuff done in a way that's really inefficient and barely will work. And of course, we've done that in many areas, and I list them here. Everybody knows this. But the important thing to remember, I think, is that we are really at a point where, well, so much has been transformed in the way we deliver goods and services. That's really not so much true of healthcare. We still do healthcare pretty much the way we did it 30, 40 years ago. And it's been one of the most difficult areas in which to make a difference. That big blue arrow, unfortunately, is covering what it's supposed to say. But the point was that a lot of this has been around for a while. The internet from the early 1990s, we got into the iPhone in 2007, really the era of smartphones. And the big innovation, the one that'll have the most impact for us, I think, is one from the last 5 years, which is the move into AI and cloud computing, which is really going to change a lot of what we can do. Next slide. If you look at what's happened so far in digital mental health innovation, it's really focused in 3 major areas. And we can just buzz through this slide pretty quickly, but I think all of you know that we've seen the transformation of interventions moving to remote, both with structured psychotherapies and coaching and peer support. All of this is now available really with a click of a button. And in some ways, that's had a tremendous effect, democratizing care, making care available. When you look at companies like Cerebral and Lyra, Cerebral now has 200,000 active patients, 5,000 providers. 50% of those people were not in treatment ever before. So it's really, there's no question that mobile interventions are increasing access. It's not clear that they're increasing quality or improving outcomes. There's a whole issue we have to think about around that. In care management, and if you click the next one, you can see that we now have the tools to do this far better. And of course, we also have the tools, next slide, for measuring. We call this digital phenotyping. But the idea of collecting data from wearables or smartphones, or using the voice and the content of speech in a way that allows us to get insights that you might have already obtained as a master clinician, terrific, but perhaps not if you're a busy nurse in an emergency room, or someone on the front lines in a mobile crisis van. And now we have the tools to be able to do this with objective accuracy, reproducibility. Pretty interesting. I think, to me, the most interesting part of this in the next slide is that if we put all of these innovations together in the way we deliver therapy and the way we deliver care, we can create a learning engine. And that's what's really important, is we can begin to get the kind of immediate feedback about whether what we're doing is working or not. And this is something that I think the mental health care community has really missed. We haven't had a learning engine for how we work as a community or as a care system. And that is not yet, I would say, truly available because of innovation, but that's where we're going. And that is very much the vision. Next slide. It's not just a vision for people who are providers, but it's certainly become a hot area for payers and for especially investors. And I put this up so you get some idea of the scale and the pace of this. It's kind of extraordinary. We now surpassing $30 billion, or almost $30 billion last year, being invested in digital health by far and away. As you'll see in the next slide, mental health is the biggest part of this. And that's really happened over the pandemic. We surpassed $5 billion in venture capital investment in mental health. I can't help but point out that $5 billion is higher than the budget of NIMH, AAA, and NIDA put together by a lot. So there's a lot of private money going into startups that are trying to innovate the way that we deliver mental health care. And what's kind of amazing to me is how little of that, and maybe none of that, has gone to mental health crisis care. And that's really why I'm here this morning, is to help you think about that and help me think about why not. Next slide. If you step back, and I'm borrowing this from Margie, but if you look at the pathway that we think about, this continuum for what a crisis system should look like, that the question you ask is, where's the duct tape? Where do we need to innovate? Where can we innovate? How do we make all of this more efficient so that we get better results and improve outcomes in a way that is workable for everybody? And I don't have an answer for that, but I think if we look in the next slide, we can begin to at least look at some examples. I mean, crisis text line was one experiment in doing one piece of this, which was moving to text as a response, training up an army of volunteers with some pretty substantial training, and asking for a fairly significant commitment. And as you can see, they have had a lot of conversations. I mean, they have had some real presence in this field. And whether they have actually bent the curve on outcomes, I don't know. I suspect not, but I think it's wonderful to see that they're trying to disrupt the field in some new ways and help us all think about, can we do this better? I mean, they obviously recognized, as their founder used to say, that for the digital natives, people under the age of 25, when they think about using their phone, they don't think about calling anybody. In fact, in a study that was done about 4 or 5 years ago, looking at the use of the smartphone, making a phone call came in number 10 out of all of the things that a phone call could do. And for young people, it's just not even on the list. So texting, chatting is the way that they would seek help, not making a call. So when we talk about call lines, that's a 20th century, not a 21st century phenomenon. Of course, there's lots of stuff that we can, complain about, that whether a crisis text line does the sorts of connections you want and whether they have the follow-up data. I don't know, but they have generated a lot of data. I think they're really interested in research. And I have to commend them for at least getting us started on thinking about how to do this in a new way. Next slide. The question really is, if we look at the whole realm of what we do within crisis next, where can we begin to innovate? And certainly, part of this is going to be around what we do with text and chat, the opportunity to have instant translation for multiple languages for many of those populations that have been so hard to reach. Not only instant translation, but also instant reduction. So being able to use natural language processing to get immediate insights into mood, into suicide risk. There's a whole science that has actually grown up a lot in the call center world, but has not, as far as I know, hasn't really been either adopted or adapted for behavioral health crisis. And there may be people in the jam who know much more about this, but this is a very rich area. It's actually one of the richest areas of AI research right now. And yet I don't know that it's something that we as a community have really tapped into. Lots more that can be done here within the call centers. You can think about what a call center is going to look like in 2040 or 2050. It's the question of whether we can get there in 2025 with what we have now. Next, it's going to be the same for mobile response. If you ask about what kind of data does that team have access to, what can they get the sort of immediate consult that they need? Can they have a dashboard that tells them all of the availability for services in the community? In the next slide. And what's available when you get to a crisis facility, and whether there's a lot that can be done there in terms of Some of it is data driven, but a lot of it is really coordination of care and a whole range of other things that we ought to be thinking about, and maybe we're not yet thinking about in terms of how to optimize outcomes. Next slide. You know, I give a lot of presentations about technology and mental health because it's the world I live in and people are really interested. And of course, there's a lot of activity in this space. And I have to confess, I'm a bit of a cynic, partly because I've been through this in both big companies and small companies. But the thing that I'm most excited about is actually not the software, it's not the hardware, it's not the apps. It's what I've learned from being in tech companies about how to get stuff done, how to build product, how to ship, how to get outcomes. And I think, if anything, if there's one thing I could do from the tech world, it would be to translate or transfer the culture of how tech companies work to the behavioral health system, because it's not the way we work. And I'll give you just 3 examples that I want to kind of convey, and then we're going to finish up. First is this one. It's about design. It's about when I first started at Google and I was putting together our first mental health program, somebody said, "What are you going to do for UX?" And I didn't even know what UX was, because in government, we never used that term. User experience. It's starting with consumers. It's starting with their perspective. You don't build anything for people, you build it with people, and you get them to tell you over and over again what's working, what isn't, what do they want, and what will they buy. It's amazing to me how we have failed to do this, and it's one of the reasons I think why we fail to make progress is we don't do well on engagement. And we don't do well on engagement because we haven't started with UX. We haven't learned how to build for consumers. Next. The other place which is really clear to me is the way in which a company like Google, or you could take any of them, because I've worked with several, but they are just obsessed. It's almost obnoxious how obsessed they are with feedback. You can't have a conversation without somebody asking you, how was that for you? Which is really kind of, I find, difficult because it doesn't feel natural. But it doesn't feel natural to me because I grew up in a world where we didn't do that. But it's constantly collecting data and improving what you do every moment. I worked with the search team a little bit, and I was stunned to find out that at any given moment, they're doing 100 to 200 experiments on Google search. You know, like on weird things like the color of the frame or the size of the font, whatever it is. And they may do that over the course of 2 hours and 10 million people. And they use feedback from that to make it better. And then they do another experiment on the same thing. Constantly learning. It's a learning culture, which we just have failed to understand and failed to adopt. And finally, the last is around accountability and the importance of being able to measure outcomes and to hold people accountable. You know, people don't understand this, but these tech companies don't actually pay very much when it comes to compensation because they pay for performance. So your base salary is probably lower than in a lot of other industries that would be comparable. But your bonus could be 70% of your compensation, and your bonus totally depends on how you perform. What outcomes do you get? Are you meeting your milestones? And those are checked every quarter in a way that's really obsessive. So I put this up here because it was so stunning to me to be in an industry that was growing and in some ways, I must say, I think way too successful. One could argue that they are the source of so much toxic stuff that's happened in our culture. But they got there because they figured out not only how to engage and how to learn and how to hold themselves accountable, but how to build stuff that people really wanted. Unfortunately, I don't think we have done any part of that in the behavioral health space generally. And I guess we could say that's probably true for crisis care as well, which is often providing care to people who don't want it. Finally, one last slide, if can. I've been wondering a lot about how do we get from here to there. And of course, the events of yesterday just kind of make all of this so much more urgent. And if there's one thing that is bothering me lately, it's the kind of lack of urgency about the behavioral health crisis we're in. I hasten to point out that, you know, if you look at the impact of COVID, for which we had this Project Warp Speed and created this huge public-private partnership, it was a way of addressing a new urgent problem that ultimately killed 1 million Americans. If you look at the people who died of COVID by age brackets, what's striking is that under 30, that is Americans under 30, we lost 7,131 people under the age of 30 to COVID from March or February of 2020 until last month. In that same time period, we have lost 75,000 people of the same age to deaths of despair, to overdoses and suicides. 10 times as many people to behavioral health issues as to COVID, young people in the same time frame. This is an urgent national issue, public health issue. And we have not brought together the best of public and private efforts to make this happen. We haven't defined it as a public health national priority in which we make this happen in any way we can, with an outcome that says we are going to reduce this by 20%, 50%, 80% by the following milestones. And that's what I'm calling for. I think the time has come to actually move forward to try to do that. Last slide, and then we can open this up. Just is the book, but mostly the book was, all the proceeds went to create this nonprofit Mindsight News. And I hope people who are on the jam will subscribe. It's free. It covers all the issues around crisis as well as many other issues at the intersection of behavioral health and social justice. It's a daily, and we're also interested in great content. So if people have ideas about topics that are not being covered, we'd love to publish them and make sure that this becomes the platform for the kind of social movement that I think we need if we're really going to begin to bend the curve. I'll stop there, and Brian, turn it back over to you. Thanks.
And thank you, Dr. Insel. I can tell you first and foremost, thank you for the incredible connections that you made. Obviously, it was a difficult balance to kind of put these together, but you did it in such a beautiful way. And the chat box really reflects how well you connected the two. There are tons of comments, and there are a number of suggestions as well within the text box. So you had put a request, and I know Karen put it in the chat box for those to give any ideas in terms of innovations or otherwise. Would you be willing at this point to open that up?
You bet. Yeah, I mean, I think we could do that. I don't know how we're doing on time, but I'd love to hear, you know, as I said at the beginning, I don't think this is an area that we've quite solved. And there's gotten much less attention than, of that $5.1 billion in investment. I don't think any of it's gone to crisis care. For behavioral health, ironically, there's been a lot of investment in innovating on crisis care for medical surgical issues.
Mm-hmm.
So there's a whole industry that is being disrupted there. I just don't see it on the behavioral health side, but it may be that it's happening. I just don't know about it. So I'd love to hear from people who have been doing this and who are in the trenches with some great ideas.
Well, considering the time, we will say that with all the wonderful comments and questions that are in the chat box, we will forward all of your questions to Dr. Insel, and they can be separately answered. He's agreed to, graciously agreed to answer them at a later time. But I do want to point out if Krista is available through the crisis text line, if you could open your line and speak to us about what you placed in the chat box. And if Krista is not available, anyone from the crisis text line?
This is Krista, but I asked a question and I think Jana was responding to me because I asked if they used it. Yeah, so I think you want Jana, not me.
Jana, thank you.
Thank you.
Thank you. I see that now. There's that technology failing me. So Jana, if you're available.
And Jana, maybe you can say something about what is machine learning and how you use it to triage, because that's exactly the point I was trying to make, but I didn't want to take the time to go into it.
Okay. Well, in the interest of time, if we don't get a response back, again, that question will be turned to you, Dr. Insel, and prayerfully you can get a response back. I do see Dr. McKeon's hand raised. Dr. McKeon?
Yes, thank you, Brian. So Dr. Insel, I would just mention the President's FY23 proposal for the National Suicide Prevention Lifeline is for 696 million. That's 100 times greater than simply 4 years ago, obviously connected to 988. But I would love your thoughts on what additionally you think Samhsa could or should be doing.
Well, Richard, I don't know that government is the place to innovate. Honestly, I left government because I began to think everything is way too slow and way too bureaucratic. I now work and live in Silicon Valley, which has done a lot of awful things, agreed, but they also have a real commitment to disruption and innovation. And I'm not sure. I mean, I think what I often feel like is if government could just get out of the way, or maybe even incentivize innovation. So in some of these proposals, to be able to provide an opportunity for the private sector to partner with the public sector to make some of this happen. It's been actually surprisingly difficult for, like if you look at the CCBHC funding, which is just crying out for going at risk, whole person care, capitated care. It's just crying out for innovation, and yet it's very difficult for the private sector to interact or to even apply for any part of the CCBHC activity. So I guess the main thing I would think about for Samhsa and for CMS is, and CMMI has done this, so I want to give credit where credit is due, but I think generally to think about that there's a whole new audience out there that is able and willing to come in and solve problems in new ways. And it's not the usual suspects. It's not just the MCOs and CBOs that have been doing a lot of this work in the nonprofit space. There are people who want to do this in a way that will be sustainable and can create an actual business model around it that will allow it to scale not to hundreds, but to hundreds of millions. And I don't know that government has really quite understood that.
And again, Dr. Insel and Dr. McKeon, thank you so much for the questions, Dr. McKeon, Dr. Insel, for your responses to all of this. There have been some powerful comments placed in the chat box that we would love for you to get an opportunity to see. Based on the timeline that we do have, I want to thank everyone for placing it in the chat box. And we want to move ahead in our program to make sure that we can get to others. So Dr. Insel, thank you so much again for everything today.
Thanks, Brian. Thanks for having me. It's great to be here. And I'll continue to be an active JAM participant as we go forward.
Well, thank you so much, sir. And we'll move now to our Crisis Trivia Hot Seat. And today we have Stephanie Hepburn, who has agreed to be part of the Crisis Hot Seat.
I mean, agreed. I don't know.
With
I think I'm going to need some moral support here.
How about voluntold?
Yeah.
Anyway, the question for you today. The IDEO team observed the roles that people play in an organization to foster innovation and new ideas and shared strategies for driving creativity forward in the 10 phases of innovation. So the question for you today, which of the following, A, B, C, or D, was not one of the top roles for nurturing innovation from the book? And we posted it for the audience to respond to, but you have A, anthropologist, B, cross-pollinator, C, devil's advocate, and then D, hurdler. So you are welcome, Stephanie, to answer it on your own. If you want to take a look at how the audience responds, I would ask at this time for the audience to go ahead and respond to the question. And you can also phone a friend if you wish.
So it's the one that's not. So A would be, B would be, C I feel like would be. This is the one that's not.
Okay, yes, it is the one that is not.
The crowd says
And
anthropologist.
right now, they're leaning towards anthropologists. Seems like comes in a second on devil's advocate and
Right.
third on hurdler.
But I can call an expert. Is that right?
Yes, you can. Who would you like to call on?
Um, is Margie on the line?
And Margie, if you're on the line, if you will unmute, please. I don't think so.
What about, is Matt on the line? Matt Goldman?
Matt, if you're on the line.
Oh, Margie's in the airport.
Okay.
Matt, I don't hear Matt
I
either.
don't see Matt, Matt Goldman, I see him on the line. Matt, if you're available, if you'll unmute.
Or I could go back to Tom. I bet he has an idea. Can I do that?
Sure.
Okay.
This is unfair, though,
Yeah.
because I work with IDEO. So, but if I can weigh in, I would go for devil's advocate.
All right, let's do it.
All righty. And the answer is, next slide. Indeed, devil's advocate. And going into the field to see how customers use and respond to products, mixing and matching ideas, widely disparate people, and overcoming limits and challenges are really the key. So thank you, Stephanie, for your gracious participation. Thank you, Tom, for keeping
Thanks,
it
Tom.
kind of open-ended. And we will move on to the next slide. Thanks again, Steph. And this is kind of a immediate movement because you don't have to go anywhere, Steph.
No.
So take it over.
Right, so this week, I spoke with Ron Bruno, and he's the executive director at CIT International. And we actually spoke in 2019 on one of Crisis Talk's most read articles that discussed how people, the mental health responders shouldn't be law enforcement. So this was in part a follow-up, but also talking about COVID and 988. And what Ron said was that there's a frequent misunderstanding about the CIT program. And if Ron, if you're on the call, if you could, we want people to read the article, of course, but if you could chat briefly about what that means.
Absolutely. Thank you for this opportunity. So CIT is, I always say it, it's one of the most well-known programs that is at the intersection of criminal justice and behavioral health care, but it is also one of the most misunderstood programs. And the reason for that is the history of it. It started realistically as a way for law enforcement to be able to respond better to situations involving crises. However, even at the very beginning, it was about diverting individuals from the criminal justice system to the behavioral health care system. That's why if you look at the very beginning of CIT, it was mandated that we had to have a dedicated receiving center that law enforcement could do a quick drop off at and get the person out of the hands of law enforcement and into the hands of the behavioral health care as quick as possible. Well, that philosophy continues forward to this day in CIT. Unfortunately, though, too many people still think of CIT as a law enforcement program. It's not. It is a community program. It is a community program in the sense that it brings together law enforcement services, behavioral health care services, advocacy, persons with lived experience, and all of the other resources in a community to look at the crisis response system and try to figure out how they can improve that system. That's really what CIT is about, the crisis response system. Now, a lot of people think that in addition to it being a law enforcement program, that it's a training program for police officers. And yeah, there is a component to train law enforcement officers and make them specialists and call them CIT officers. But that isn't the main focus of CIT. It is really about reforming crisis response. And the thing that we're looking at when CIT International looks at crisis response and reforming it, there are three things that are really guiding principles. We want to make sure that the crisis response system is the most compassionate it can be, as well as the most effective it can be. And nobody disagrees with that. Everybody kind of goes, yeah, that's great. Yeah, we agree. But where there is a misunderstanding is the third one. And that is that it should be the least intrusive in the lives of somebody with mental illness that may go into crisis, the least intrusive. That's why we advocate that we need to look at 988 as a great opportunity to be able to divert from the criminal justice system right up front.
Right.
Train our 911 call takers to triage that and hand it over. And then the next step is that if we do send somebody out, it doesn't have to be law enforcement. We've got to realize that sending law enforcement out is not required. If you ask any 911 center, if you ask any law enforcement officer, do the majority of crisis calls require the presence of an armed law enforcement officer? They're going to say no. So we need to make sure that those are being handled by the mental health care system. We do see a push for embedded co-response, where we take a law enforcement officer, put them inside a car with a clinician. It's a great concept. It really is. And it's much better than just sending out law enforcement. But again, what we're doing is we are demanding that law enforcement be present at every single crisis call.
Mhm.
In addition, when they're not needed, basically law enforcement is just standing around while the clinician is providing some clinical benefit to the patient. So do we need that? No. Will there be times that law enforcement needs to respond? Absolutely. And that's why it is so imperative that we do have a cadre of law enforcement officers, specially trained to be able to work with a person in crisis that is exhibiting signs that they are a danger, substantial danger to themselves or others. And then we also need to train that law enforcement CIT officer how to work with the behavioral health care crisis response team, the non-law enforcement team, so that way they can be dispatched out together. They can show up on the scene together. And if we train the behavioral health care team how to work with the CIT officers, guess what? We have the exact same benefit as having an embedded co-response, but we don't mandate that we have to have law enforcement at every single call.
Thank you so much, Ron, for hopping on the call. I think the one last bit that I thought was really interesting in our discussion, and people can read more about in the article, were the calls that you're starting to get that are really shifting the needle to upstream to those 911 calls. Is that right, that you're getting more community calls about? Can you chat just a little bit about what they're looking for?
Yeah, absolutely. So there was a lot of discussion. A lot of people were reaching out to us, asking us about, because we talked about the triaging with 988 coming down. And a lot of people did talk to us about, hey, is there any training for our 911 call takers? And so we did get together with subject matter experts throughout the country, and we developed a course that CIT International does offer any and all 911 call takers. And basically it is to train the call taker on how to recognize that they're dealing with a behavioral health issue. Number two, start the de-escalation process. Number three, what kind of information that they should have. Number four, triage the call, make a determination whether we do need a law enforcement officer response. And if not, hand that off to 988, hand that off to a local crisis line. And then fourth, if we do need to have our CIT officers respond out, what type of information would be most beneficial to give to that law enforcement officer as they're responding out?
Thank you so much. We'll send it back to you, Ron. Send it back to you, Brian.
Thank you. I appreciate the opportunity.
Thank you, Ron,
you.
for that information. I'm going to kind of jump ahead, if you don't mind. We're going to go to our Samhsa report. And Dr. McKeon, if you're available, go right ahead, sir.
Thank you very much. Much appreciated. So there were two things that I would highlight. So one is that yesterday the FCC hosted a forum, which Samhsa was very engaged in helping to plan on geolocation for 988. Many of you may have seen it was live streamed, and it's now, and it was recorded. So my understanding it would be available for you to look at. And I would suggest that you do. I thought it was a very valuable conversation with input from technology leaders about options for moving forward, discussion about really the different levels of geolocation, the directing calls to the area where the call is actually coming from, on the one hand versus the precise location that's needed for emergency intervention. I moderated a panel on consumer perspectives, which I thought was very relevant and had some good ideas. The way I would summarize that panel was that those who participated indicated that there could be significant value in geolocation for 988, but there also needed to be safeguards. And they shared some intriguing ideas for what some of those safeguards should be. So we're looking forward to following up with that. The other thing that I would like to mention, and I'll put this into the chat, is that SAMHSA just released our funding opportunity for our mobile crisis or community coordination grants. The SAMHSA was given in the Omnibus Appropriations Bill $10 million in order to support this, to support the mobile crisis, but also its coordination with a range of services in the community. And we know $10 million is not enough to substantially increase other resources going to mobile crisis. So we're really hoping that these can be grants that can advance innovation and equity moving forward regarding mobile crisis services. So that just came out in the last 48 hours. I will put that into the chat. There are a broad range of eligibility for who can apply, and we certainly hope to get a very strong response. So thank you, Brian.
Well, thank you, Dr. McKeon, and thanks as always to SAMHSA for wonderful, wonderful leadership in this. We're going to move to the Nashville updates, and I'll be giving just a brief update. I just wanted to make aware of Nashville's ongoing efforts, and it was almost perfect that Dr. McKeon had mentioned at the latter portion about work in equity, because Nashville has been working along with SAMHSA and really enforcing and helping states to enhance their equity efforts. And it is just a shout out to many of the states that are doing some incredibly good work in working in equity as it pertains to 988 implementation, that many of them are implementing very unique programs that we are really proud of and sharing with others. And it's information that really is moving us forward. And many of the states have a collaborative effort to speak with each other about those kinds of efforts. So it's really a wonderful movement. So with that, we'll move to the next slide, please. Okay, at this point, we can call on Sarah. And Sarah, if you'll give us some brief updates.
Yeah, thank you so much. So just now that we're towards the end of May and Mental Health Awareness Month, I'll give a quick update about some of the activities that have happened with the White House, and then we'll switch into some of the committee authorization. If we can go to the next slide quickly. So there was a proclamation earlier this month from the White House commemorating May Mental Health Month, Awareness Month. Earlier this week, there was an event with VP Harris and the Surgeon General at the Children's National Hospital to talk about health worker burnout and mental well-being. So that continues the very awesome slate of events that the White House and the administration have been putting on this month to really highlight the mental health part of the unity agenda of the Biden administration. On the House Ways and Means side, we've heard some rumblings that they might be interested in doing an authorizing package of perhaps some mental health Medicare work. It has been very slow amount of information coming, and we're not sure where they are on the timeline, but that is something that we've heard might be of interest for Ways and Means. On the Senate side, that Senate finance package that there were RFIs put out last fall, the different work groups, the 5 different work groups, had their deadlines to submit information to committee leadership towards the end of last month. We're hoping that we might see a draft of potential legislation coming out of the Senate Finance Committee sometime in June, but that does depend on a few different things, but hopefully as early as June, we might see something, and they would likely have a markup sometime later in July after the 4th recess. On the Senate Health side, it's a similar pathway. That's in conjunction with that Senator Cassidy, Senator Murphy bill that was introduced a couple weeks ago at this point, with some of those SAMHSA and HRSA reauthorization items. That is, as far as we are aware, discussions are underway with HELP leadership on a bipartisan basis as well. And we might see something as soon as just before the July 4th recess, but at this point, it could be more likely after July 4th recess with another markup. So it's going to be a busy month of July in the Senate. I will turn to Joanna from AFSP to talk about the energy and commerce portion of the reauthorization process.
Yes, so as we said, the Energy and Commerce Committee is exploring reauthorization. The HR 7666, Restoring Hope for Mental Health and Wellbeing Act. Last week, the committee held a markup of several health bills, which included this one. And this was reported favorably to the House by voice vote with several amendments. So we're looking forward to that going to the floor hopefully soon. I don't believe we're aware of a date yet, but we're keeping an eye on that. One of the amendments that was included was from Representative Cardenas and includes several parity provisions that are in the 988 Implementation and Parity Act. Some other amendments that were included include provisions for mainstreaming addiction treatment, peer support for mental health, and medication access and training. So like I said, the bill is going to go to the floor soon. We're excited to see that, and I'll end it there.
Alrighty. Well, thank you both for such a detailed discussion, but also a very timely discussion. Thank you so much. We'll move to the next slide. And again, this is highlighting the states again, and I believe someone from Vibrant, if you would come on, just to give a brief overview. Go ahead.
Hi, yes. Hi, thank you, Brian. So Kansas, the Senate passed SB 19 on Monday, which approves $10 million for 988 implementation, and right now it's awaiting the governor's signature. So that's the update for Kansas.
Well, thank you so much, Shelley, for that info. And let's move to the next slide, please. And in these, again, they are consistent highlights of the various states, Virginia and Utah and Nevada and Washington State. If we could have maybe just a brief comment from someone from Washington State, if they would like to comment on their particular slide.
Well, thank you. This is Tina Orwell, a state rep from Washington. And, you know, I just have to say the Seattle Times, which is our paper, did a beautiful article this week on our trip to Arizona and just all the lessons we learned. And so we're really excited. We have great energy coming back. We are meeting with our private philanthropy to see how they can partner in some of these changes. And again, this really strong working relationship between 911 and 988. And when I told my police chief we were going to marry them, he said, will there be a prenup? But, you know, we're having all these great discussions of how we're going to work together, co-location, cross-training. So a lot of exciting work.
Well, thank you, Representative. That is so wonderful. Thank you so much. And thank you for all your efforts. Next slide, please. And I'm wondering, with the amount of time we have left, Tom, if you're available, if you'd like to speak a bit on the calculator.
I believe Tom Butler goes on.
Okay, sure.
I'm saying he's not on. Sorry.
Okay, well then next slide, please. And this is a reminder again about Moving America's Soul on suicide. We now look at what's been happening in the past 24 hours. It's also an acknowledgement and opening the doors that suicide is a huge theme that is intermixed with everything that we're doing right now. So it's raising an awareness of the presence again of these particular series. And we encourage you to keep up with these particular films. Next slide, please. And as we draw to a close, I did want to just open up our sessions, our crisis jams that are coming up, particularly the one next week with Dr. Carol Olson, speaking on comorbid medical challenges in crisis. And just an acknowledgement that we've really not spoken on this topic. So we encourage everyone to be present next week for this particular topic. I think you'll find it to be incredibly insightful and incredibly information bearing. But as we look ahead, we recognize that we have a number of outstanding individuals that are going to be speaking to us in the up and coming weeks. So this again is a testimony to how wonderful things have been moving and the interest level and the commitment that people are making to continuing our crisis jam, and as well the implementation and making it more resource driven for the states. And next slide. And with that, I would like to thank each and every one of you for joining this special session that we've had. There have been a lot of in-depth discussions, and again, as I mentioned earlier, all wonderful comments that have been placed in the chat box. I thank you for your involvement, folks. I thank you for working with us, and understand that those chats will be forwarded to the respective parties, and they will be getting back to you with responses. Thanks again, and my thanks to our speaker, Dr. Insel, and to all of you. We say good day. Have a wonderful rest of the week. Bye now.